approach. So I work as a consultant neurosurgeon and spinal surgeon in Belfast, Northern Ireland, and although I still keep some of the cranial practice, not as high level as Sabino, but my main focus at the minute is spinal neurosurgery. So I just wanted to present to you that slide that shows you how the technology was developing in spinal surgery. You can see that in the beginning of the century, basic spinal approaches. Then somewhere after the Second World War, we started to develop more complex approaches, the first PLIFs. Then we have 1963, the first OLLIF, 82 was the first TLIF. And then after 2000, we started developing minimal invasive approaches and also endoscopic approaches. So you can see as a result of that, we have now multiple approaches, which are minimal invasive approaches developed to every single open approach. So you have at least 2-3 minimal invasive options to every open option. So we are living in a boom of minimal invasive and endoscopic spinal surgical approaches. So I'm going to present to you a case. This is a 49-year-old female, very active, running marathons. Unfortunately, she was not possible to do that because of degenerative spine disease. You can see there is a grade 1 spondylolisthesis on the MRI scan, which is degenerative spondylolisthesis. That is further slipped if the patient goes up due to the gravity. So that is why the patient is not possible to run. She's okay when she's not moving, but when she is axial loading, she is very unwell. So what I have done to her back is endoscopic or EndoLIF approach, which is basically transcambin fusion approach. With that approach, we are not anymore needing to do facetectomies. We are not needing to do any bony work in order to put the cage, the interbody cage. We are doing the cage through the foramen. This is in a way counterintuitive approach before you start, but as you start and you start understanding the approach, that makes perfect sense, because the technology now is allowing you to dilate the foramen safely without damaging the exitive or traversing nerve root, and it's giving you a lot of instruments to prepare the disc space in a way that is appropriate, so you have a good fusion rates. So I have no problems with the fusion rates with that technique, and I have no other problems with the technique. With the selective cases, of course, selected cases, this technique is a game changer. As you can see, the procedure took about 70 minutes, but this is still something that will improve with time, and the hospital stay of the patient was only 24 hours. The cage that I'm using is expandable cage that is coming collapsed, and then inside the body, as you can see, I was possible to collapse it. So I'm going to tell you, of course, the time is not enough, but I'm going to give you just a few points. Obviously, that topic can be discussed hours, not 8 minutes. So this is the way we are still, even now, we are teaching our residents to approach the spine mainly medial to the facet. However, with that technique that I have just presented, you go completely different approach. You go outside of the facet, and this is a completely different perspective and completely different approach to the spine. So this is something that you have to learn separately. This is still, unfortunately, not as part of the mainstream curriculum, but it is becoming more and more popular and more commonly used. So you have to think, if you're in the early stages of your surgical training, or if you're already graduated from your training, but you are in the first years, this is something that you have to start considering to teach. This is the area that you can approach with that technique. You go through the foramen. You can see that if you really zoom in, the foramen is not really this small, and there is a lot of space for you to do a lot of things. You have to know the anatomy, and you have to know the relations between the nerve and between the other structures, so you can safely are possible to insert all of the instruments, dilate the space, and go and do the work that's necessary. You can see this is the small place that you address in the beginning. This is the Cambin's triangle. So always you have to place your instruments close to the lower end plate. Lower end plate is your friend, and if you go closer to the upper end plate, you are putting inevitably the exiting nerve root at risk. What you have to know as well to do that technique is you have to be possible to read the X-ray anatomy. That technique is possible to be applied with a simple X-ray. I don't use even navigation for this technique. Some people use one, some people use two X-ray machines, which are giving you AP and lateral. I personally use just one X-ray, but good X-rays are crucial for minimal invasive spinal techniques, because taking good pictures and understanding the pictures appropriately is going to give you, that's basically going to be your eyes, because unlike the open surgery, the minimal invasive surgery is not giving you anatomical landmarks. You're doing everything through the skin. So true AP means that the spinous process is right in the middle, single line of the end plate of interest. These are very important characteristics of the true AP. Same thing of the true lateral AP. You have to be very sure that you are true lateral, otherwise the parallax can cheat you. It can give you a false reassurance, and you may do something wrong. So true lateral means that the end plate of interest is just on the just a line, and the rest is a 3D spatial awareness. It's a matter of I do 10-15 minutes planning before I start my cases, and you can see this is how I draw on the patient's back before I start the surgery. Very important 3D spatial awareness for you to be possible to constantly track the tip of your instruments on AP and lateral in order to get the right pictures and right position. Last thing that I'm going to tell you, if you are planning to do that surgery, that procedures, start with injections. Doing injections will give you a chance to understand the X-ray anatomy, and also will help you to understand the trajectory. You may have complications, and you have to understand the X-ray and how to keep yourself safe using the X-rays. Thank you.
So I'm